Ladies and gentlemen, please join me in welcoming Dr. Lee Yong-ju to the podium to enlighten us on the fundamental aspect of spine endoscopic surgery.
Good morning, everyone. I'm here today to show you on the latest and greatest in the world of spine and help you to get a new life, not only to a patient, but also a doctor who learned this PSLD surgery, endoscopic surgery today. The new life means like, this is the founder of PSLD, Mr. Hong's life philosophy is also in it. So this session is about the basic tips of endoscopic spine surgery. I'm Dr. Yong-ju Lee, anesthesiologist and pain physician and also endoscopic spine surgery. And I'm a president doctor of my own clinic, Seoul Endoscopic Spine Center in Seoul, Korea. Here's how my GPT4o helped me design a brand logo of PSLD with my image. Do you like it? Yeah, so I even asked to GPT4o, 41-year-old businessman who travels a lot for business, and he got sudden disc herniation with stenosis at 4.5, so wealthy enough to choose best surgery option. So which one would be the best? So the answer is boom, like endoscopic spine surgery. Even ChatGPT, it officially agrees that minimally invasive surgery like endoscopic spine surgery are the best option for the patient who needs to get back to work life and back to quickly, because life is short, so we don't have time to be in pain. That's why we're here to learn PSLD today. So here's the contents, preparation procedure, cases, and messages. Preparation like this. This is how it looks before I make an incision to a patient's skin. And specifically, it's a cervical, but almost same. We even do cervical with just the tape. We don't need any special tool for the even cervical. The lumbar are the same. At the spine position, we do like this. I will show you one by one. You need all of these equipments, but that's not too much. So one by one, I show you. You need all of these. There's the first one, video equipments are the very important one. You know that light camera imaging processing. And here is the spine endoscopic set. As you know well, transforaminal type and interlaminar type. But also you can do para approach with the interlaminar type. Here's the video stenoscopy. Length is like this. Outer diameter, working sleeve are only within 1 centimeter. You know well. And the spine table, just like this. But you don't need very special thing. Just head and feet with something on the bottom as a pillow. And you need coagulation equipment and drill system as well. And you might also need irrigation pump actually, but I don't recommend much because natural drainage is very available and safe enough, because I prefer natural drainage because of the pressure from an irrigation pump could be very dangerous to the dura and might increase brain pressure. And one of the cool thing about PSLD surgery is that it's a underwater surgery. You know, irrigation is very helpful in a various way. Number one, you will get very amazed by the very crystal clear view of the anatomy. Because of the irrigation, you get very clear view of that. And second, the continuous irrigation is also very helpful, because the tissue debris are washes off when the body thinks a foreign body tries to eliminate it through inflammation, but there is also another benefit of irrigation. So endoscopic surgery has multiple levels of benefit. And here is anesthesia. You will choose 4 types like this, but as a beginner, I recommend general because the time surgery is not very regular, so I recommend for the beginner. But once you get really advanced, you can try the second one, epidural with sedation, very stable. We do usually epidural with sedation with mask holding, but very in an extreme situation like in Africa, you can try with the local also. It is very plausible. Here's my photo. Yeah, so this is my bag. You only need one assistant, and you can even attempt it on your own. That's another benefit of this PSLD surgery. but try not to do by yourself. It's a bit tough. So here's the procedure of endoscopic spine surgery. There are 3 approaches. As you know well, transforaminar, very traditional one, and interlaminar, and there's paraspinal approach. You know very well the indication of transforaminar, so I'm gonna skip. The interlaminar approach, almost 90% of all the cases you can solve with this interlaminar approach. Paraspinal, you may not very familiar with this, but it is very also important. It's different with transforaminar approach, especially like extraforaminal Faro syndrome. You can only solve with this paraspinal approach. So you can think about it. I'm going to show you later the cases. So how do we approach? You can do level check, entry point check by using CM in the surgery room. Here's the short one, transforaminar. You can do like this, AP, lateral, checking. Interlaminar, AP view, you can just next to the approach to the next to the spinous process. Lateral view, you can make a alignment with the lower end plate. So here is the entry point, 1, 2, 3, 4, like that. You can do bilateral. Make it, but entry point near the midline if possible, because facet preservation is very useful with this. You do like this. Yeah. So I'm gonna show you one of my video. This is interlaminar approach. This is the upper laminar here. And using the punch, you do one by one safely. And you notice there's a ligament flavum and lamina are detaching. So, and you also find it with touching with the lower lamina and find the lower lamina, and one by one you can detaching. You see a lady doing this. So with interlaminar approach, you know that you can do the contralateral also. Paraspinal approach, you do just 1 centimeter away from the lateral pedicle line. It's an extraforaminar space. With the lateral view, you can align with the upper end plate. Do like this. Do like this. So here's the cases. I'm gonna show you like with 4 different cases. Case Koda Equina. It's just last week we did the emergency surgery before I come to Bangkok. He, young 24 male, he often experienced lower back pain but didn't take symptoms seriously. But now he feels suddenly weakness in the left leg, perineum paresthesia, and bladder dysfunction. So we decided to do emergency surgery, 2 level, but usually we do 1 level but control lateral, but we decide to do, because it's quite dangerous and emergency, we do 4 holes over here. Like this, there was a severe 5S1 herniation, 4-5 herniation. It's a pre-OP MRI. And after that, we make a hole. Yeah. And now he's really lucky, get back almost 95% of the function all at once. So there was a huge disc coming out with interlaminar approach. We make a small annulotomy hole, and then we picking the disc, really a lot coming out. So the one thing I want to recommend you is that try not to make a disc in a one shot. Try to make a nerve root retractor with the forceps and make just a small annulotomy hole and make a snap on it. Try to do a lot. Try not to do in a one shot. Try make a small snap. Then you can make a complete disc remover of it. So here's the second case is recurrent disc herniation. I'm going to show you 2 recurrent disc herniation. Also young male. He 5 years ago he went on already best surgery for 5S1. So I at first I didn't take it seriously, but we did PSLD revision just right there. But just 2 days later, he got complained a lot of severe pain on the left leg. So I'm gonna show you. It was before the surgery and after the surgery, actually more coming out. So we did redo the surgery. So I was thinking why this happened. So the thing is that 5 years ago, he already had the best surgery, but at that time, the annulotomy hole was quite big, so I didn't expect it's coming out again, so I couldn't help, but we did redo the surgery, and he's fine now. And second recurrent disc herniation, also young male, he got radiating pain on the left leg, he had a left like disc herniation. So after that, he was fine for 4 months, but after 4 months later, he got lifting a heavy box at work, he recomplained, so we did the MRI exam, and another small disc was coming out at the foramen, so we redo the surgery. So it was a bit different. The case before, it was just 2 days later, but this one, he couldn't take care well of his back, so it was 4 months later. So I want to say about more recurrent disc herniation. You know that it happens about 5% of the time in the first 6 weeks. Usually, this is quite pretty high. Unfortunately, there's not much that can be done about it. So in 1 in 20 patients will have a recurrent disc herniation. The best data that we have why that occurs is the size of the hole of the annulus after you get done with discectomy surgery, the first discectomy surgery. The bigger the hole, the more likely a fly will enter your house. It's the same thing. So there's also genetic predisposition. We cannot do anything about that, but the things that can we do to mitigate the problem is that try not to make the annulotomy window too big. The size of the annulotomy defect at the end of surgery directly correlates with the risk of recurrent disc herniation. So you want to do the surgery as minimally as invasive as possible. Aim to create a minimal annulotomy during the first operation. So here is paraspinal case. Male 63, he was fine with it. After lifting heavy box, he complaining right leg radiating pain to the anterior thigh. And so I did L4 right root block, and very effective for a day, for half a day only, but did not last longer. So I diagnosed him with extreme severe foraminal stenosis at right L4. So we decided to do the paraspinal view. It's a pre-MRI. You see the four, not like the left, the foraminal view. So after that, you may not notice much on the MRI view, but paraspinal is like this. So, but symptoms so much good on it. He didn't complain after all. So paraspinal approach, maybe we're gonna show you live surgery today, so you will see one cases of paraspinal. So here's the things. It's the upper trans process, and there's the isthmus on the upper side, and you see the root is coming out. You using a lot of curette at these cases and removing things and clearing out. That's a paraspinal approach. So you see the nerve coming out and complete. This is simple, but once you approach very well and diagnose very well, it's really good surgery, paraspinal. So why do we need spinal injection? The main reason is to get the patient better without surgery. But it also helps with diagnosis. Identifies exact anatomic location where your pain is coming from. If that is the location where your pain is coming from, you will get temporarily better. You notice that a certain activity that causes pain a lot is no longer cause of pain. It means positive diagnosis. So even though some surgeon might think spinal block boring and bothersome, I strongly recommend considering targeted injection when planning surgery. They can make a significant difference. Once in a while, if we are lucky, they get better and never need surgery, but at the very least, rule in or rule out the specific pain location is very important. If it turns out it's not the pain generator, we just can keep looking it because having an accurate diagnosis is the most important way for a surgeon to be successful. Here's the spondylolisthesis. I bring you the two cases. So here's very severe. You see the grade 3. So we did paraspinal on the right side. When you see on the video, it's very extreme. But after that, he really get fine. So surprisingly, even at first I thought she might need the fusion cases, but with paraspinal cases, you solved really extreme cases. So my patient always asks me why my spondylolisthesis causes me so much pain. There's two reasons. The spondy is simply one vertebral body moves forward relative to the other, it creating micro instability. This grinds back and forth with movement, causing wear and pain. Also overload facet joint, leading to stress and pain. The second reason is that imagine there's a tunnel inside, and the other one moves forward. It's like geometrically, the nerves inside in the center get crowded and pinched, so it makes a aching, heavy, numbness, tingly like this. So here's another spondylolisthesis cases. At first, I thought it was just grade 1 spondylolisthesis. So when I do the bilateral decompression for 5, especially if I grind back interspinous process, that could be just fine. But he was complaining a lot for 3 months. So I give him a lot of core muscle exercises and pelvic imbalance collection. After just 3 months later, he reported no pain at all. And I was happy about that. This was the case. And even just after this MRI, she was really severely complained. So here, the cases, I was thinking, this spondy case, we can see maintaining muscular control is very crucial to educate patients. It's very essential to emphasize the importance of having the back muscles surrounding their spine, not only be strong, but also well coordinated. So they act like a world's greatest back brace. Also, as a surgeon, we must try harder to minimize collateral damage during surgery. It's very important to avoid injuring the back muscle that provide this support. This is why we employ techniques like PSLD surgery. So here, people still, if you have a question, why PSLD, still why PSLD? I'm going to show you. There was in 2021, a few years ago, there was a gunshot from a patient who complained a lot of pain after the spine surgery. So he got gunshot of his doctor, so it was really tragic. So I asked to the GPT4o again, this gunshot, so what happened, what was the best option? So the answer is PSLD. So I need to confess something, I educate the ChatGPT4o some a bit, so but still, boom, like officially ChatGPT agrees that minimally invasive exposure PSLD surgery are the best option. Here's why, blah, blah, blah. Quite smart, like he reduce option, pain and recovery, high precision, lower risk of complication. You see, 1 incision only, 1 hour surgery time, 1 day hospitalization. PSLD is very safe and complete. Try to find anatomical structure under the endoscopic visualization, and you will overcome very well. And please knock around you. Many experts are waiting for you to help you. So thank you very much for your attention. It was basic tips of endoscopic spine surgery, and Dr. Lee, thank you a lot. If you have any questions, feel free to ask me.